Now we call upon the last speaker, Dr. Sangeet Bhatnagar, for this presentation.
Good morning, everyone. I'm Dr. Sanket, and I'll be presenting my study on comparing accuracy of toric power calculations with an anterior segment swepsode OCT with standard devices. I have no financial disclosures. So, with increase in incidence in astigmatism and demand for better, more accurate post-operative results, conundrum of solving astigmatism power in phacosurgery has been there for phacosurgeons for quite some time now. So whenever we want a precise or accurate biometry, we need good topography, good excellent measurement, pachymetry to come to a conclusion that, okay, we can give a reduced SIA post-operatively. So there are a number of machines at our disposal, most of them biometers, topography, abrometry, but most important or most pivotal is topography and biometry for toric calculations. But whenever we send our patients, most of our patients are in senile age group through these battery of tests or scans, what we see it's very cumbersome, very time consuming, and also it puts a financial strain on the practitioner as well. Thus, COVID also has shown that we should shift our protocols. We have to shift to lesser contact points and shorter imaging protocols now. So this begs us to ask that is there a single imaging platform which is reliable or which can give us comparable, if not more precise biometry or keratometry for toric calculation compared to standard devices that we have already. This brings in the Heidelberg Anterior ASOCT into picture, which is a multimodal imaging platform which is optimized for anterior segment imaging. It utilizes high resolution SEPSOS OCT with 1300 nanometer wavelength, which gives us larger scanning depth of around 31 millimeter, and has low scatter. It also combines topography and tomography with biometry measurements, has eye tracking technology for faster acquisition time, and Oculix, which is a ray tracing software which you can incorporate into the machine itself. So a single imaging platform can give you biometry, topography, anterior segment imaging, and it has an inbuilt toric planner. But can it replace our standard topography and biometry devices? So that's where we conducted the study, with the purpose being to compare the reliability and agreement of parameters which were measured between Heidelberg, Anterior, Carl Zeiss, IOL 700, and Oculizer. We also studied the residual corneal astigmatism post-operatively, which was achieved by Anterior and with conventional devices, and we assessed the mean prediction error as a gauge of accuracy. So it was a prospective interventional study of 42 eyes of 32 patients who between 50 to 75 years of age had acquired senile cataract with an astigmatism of more than -1 diopter with normal corneas, no other ocular pathology, and no previous ocular history. All these subjects underwent clear corneal phacoemulsification by a single surgeon where a temporal 2.2 millimeter incision and a toric monofocal aspheric IOL implanted. So pre and post-operatively, the patients underwent visual acuity, refraction, and detailed slit lamp examination. Mean keratometry, astigmatism, pachymetry, axial length, and IOL biometry was measured from both IOL Master and Anterior. And from Oculizer, mean keratometry, astigmatism, and pachymetry were measured. So coming to the toric planning, we compared the biometry and topography from IOL Master and Oculizer, and we used the Alcon IQ toric calculator. Parallelly in anterior, the biometry and topography gave us the measurements with the same formula, which was SRKT and A constant, and the whatever we got from the Oculizer and IOL Master, we incorporated into the Alcon calculator, and Alcon AccuSoft IQ toric monofocal lens was implanted. Coming to the results, in a sample size of 42 eyes of 32 patients, the mean IOL power implanted was plus 23.25 diopters, and there was a statistically significant change in visual acuity, change in corneal astigmatism, and mean spherical equivalent. Now, to survey the repeatability of the parameters they were measured, intra-class coefficient was evaluated, and Anterior showed moderate to good repeatability with excellent repeatability for axial length. Now, comparative analysis of all the parameters that were measured, which were mean preoperative astigmatic power, keratometry values, axial length, and pachymetry, though there was no statistically significant difference, but there was no variability also between the devices. Coming to the Bland-Dolman plots for agreement, both Antirian and IOL showed favorable agreement with excellent agreement shown for axial length. And axial length was so much agreeable that we saw that it can be interchangeably used also. Now coming to the mean prediction error, our accuracy was gauged by the mean prediction error, which was calculated as a difference between the target or the predicted actual residual astigmatism and the actual that we achieved. Though it was not statistically significant, but Antirian calculator gave us a lower predictive error compared to the online calculator. Also, the keratometric error the range was lesser in Antirian. So what we already know is that predictive accuracy of toric IOL power calculations depends on both precise biometry and keratometry, and multiple biometers and keratometers are available, and a composite workup on all these is required to do a toric IOL power calculation. But what this study adds is Antirian shows good to moderate to good repeatability, and good agreement between Antirian and IOL master is still present, and it has a lower prediction error in toric calculation compared to toric calculation which was done by conventional devices. Just to conclude from this study, Heidelberg Antirian with its longer wavelength and larger penetration depth can be used as a single platform biometer and keratometer for toric IOL power calculations, but this study was not without its limitation. We had a smaller sample size and the follow-up period was only 1 month post-operative period. Also, the toricity of the IOL implanted was not taken into factor, which can be a confounding factors also. Also, vector analysis is still to be done because the sample size is a little low. So that's for the future direction. Thank you.
Thank you, doctor. That is a good presentation.
So, just for the sake of knowledge,
Yes, sir.
Antirion also gives you a posterior float
Sir, it gives us a posterior float. It gives us a total corneal
as good
cover.
as good as the pentacam.
Sample size is less, but reliability is good, sir.
Okay.
Plus, it can give us a epithelial thickness map also, sir. So on anterior
So that is not for cataract surgery. Epithelial thickness.
posterior float it's giving.
Posterior
sir.
float is
Yeah,
more important when you're talking about toric IOL.
Yes, sir. So it uses that as a parameter for toric planner, which is incorporated into that, sir.
Okay.
Yes, sir. It gives.
Okay. Thank you.